Assalamualaikum doctors, good evening. Welcome to our 19th session of recall-based discussion. So here we have a list of topics. So first topic we are going to cover is fibroadenoma. So let me take you to MTB. Page 977. So when we say fibroadenoma, so for exam point of view, you may find many questions related to masses of course in the breast, and that can be mobile masses, that can be firm masses. So it's pretty difficult sometimes to make a clear diagnosis. So they usually give you a very clear clue in order to make a diagnosis. If they really want to make us, to make a definitive diagnosis, they have to give something which is relevant to that topic. So if you are considering fibroadenoma, what you will always find. Yeah, Assalamualaikum, Dr. Tareen.
Yes. You joined? You started already?
We just started. Yeah.
Okay.
You're not late. You're on time. Okay, so I'm just saying that we have, for the first topic we are going to cover is fibroadenoma, and especially the masses in the breast questions are very, sometimes it's very difficult to understand, but in order to make a clear diagnosis, we have to have some very important clue in the question so that we can easily go over that question. Say, for example, whenever we are considering this fibroadenoma, the very important thing which you will always find and you will look in the question, that whenever the mass is there in the breast, especially what is the position of that mass and whether it's firm, whether it's tender or painful, and a very important thing, whether it's mobile or not. If you just move the mass, if it's moving or not upon examination. So we have to have all these features in our mind, then only we can make the diagnosis. So if you are considering fibroadenoma, so this adenoma word means it's a benign solid tumor. Benign means that, of course, whenever we are considering tumors are always painless. It's not about benign, it's not about malignant. Whoever the tumor is, tumor will always be a painless lump, always be a painless mass. But whenever it says painful, so always think about abscess, always think about infection, because tumor will not always present with any kind of pain in the breast. So here it's a benign tumor, it's not a malignant one, with glandular and fibrous tissue. So it's all composed of fibrous tissue. That's why it will give an appearance of well-defined mass. You will not find an irregular margins of this tumor. Of course, it will give you a just feeling of a lump that has well-defined margin, and it should be a mobile mass. When you do the examination, it can move between your fingers, your index finger and your thumb. You can easily rotate them. Most of the time, if we have this adenomas, they are usually bilateral, like you can feel in both breasts if they are there. May increase in size with pregnancy. Of course, masses and especially these fibroids, they are just, they just act like a fetus. Like during pregnancy, fetus is growing. So these masses are also usually growing. And with the passage of time, when the women are not fertile, then you may find that these masses are usually regress at that particular time. So like say, for example, in 60 years old, in 70 years old, you may find masses, but that should be a regressed one or a sclerosed one. They are not they don't have a tendency to increase in size at that, because of hormonal deficiencies. Of course, during menopause there will be no more androgens, so that these masses will not grow. So especially we will see that in case of pregnancy, if the woman is pregnant and she has this benign mass in the breast, maybe you will see the size is increasing, but of course we have to rule out from the malignant condition. And of course, when the menopause is there, then the size will be decreased. Whenever you want to go for the diagnostic purpose, you will always do the ultrasound. So ultrasound will always be the best initial test whenever you want to see what is there inside. And we will learn also later in the screening part that mammography should also be done as a screening procedure in all women who are more than age of 40 years, starting from the 40 years and more than 40 years, a mammogram should also be performed. But of course, when we are considering about the definitive diagnosis, where we want to see whether the mass is benign or whether the mass is malignant, we have to go for especially this core biopsy, middle core biopsy. We have to take the samples and we have to observe that sample under microscope in order to see what's the pattern of those tissue, whether it's a benign tissue or it's a malignant tissue. So we have to go for the biopsy, but never choose biopsy as the best initial one, because ultrasound is the one where you usually pick the disease, and in order to see the histopathology of the disease, of course you will go for biopsy. And when we are concerning about the treatment part, so here we will just observe with repeat ultrasound if the masses are too much big. Say for example, you can just ask the patient to follow up every after 6 months just to see whether the size is increasing or not, because most of the time these masses are actually don't do anything to the patient. They are usually asymptomatic. But if there are too many and they're causing pain, not pain in that point of view, but overall heaviness of the breast is there, then we can always think about to remove these masses. So of course we can excise them, and we have to always go through the biopsy of these masses just in order to check whether they are the benign and the malignant ones. So that's very necessary. Only on the basis of ultrasound we cannot sit like, we cannot sit for relaxation like it's okay, we can just leave it and we can just follow up every after 6 months. No, it's not a good choice. Once you confirmed on ultrasound the mass is there, lump is there, you may find that the mass is regular one and mobile and everything is there, so you can make a diagnosis of adenoma. But of course without biopsy we cannot say it's a malignant one. So for fibroadenomas questions, especially if we are considering MCQs, always look for the age of the patient. Age of the patient is very important. Then we will see whether the mass is mobile or not. So mobility of the mass is very much important once we are making a diagnosis of fibroadenoma. Age of the patient is very important. And of course, if we have any findings of ultrasound or biopsy, that will be an added advantage. So just have a look at the question here. Here the question says a 19-year-old woman. So she's 19 years. Of course, she's in fertility age, and of course she must be an unmarried up to, so far. For a 4-month history of left breast mass. So she has this unilateral mass. It's okay. Most of the time, in 20% of cases, we may find bilaterally, but of course, 80% can present with a unilateral presentation. On breast examination, confirmed a well circumscribed, firm, smooth, mobile lump. So whenever it says circumscribed and this firm and smooth and mobile lump, so it all emphasizes also is there. It's not very much big. It's 2 into 2 centimeter in size. So of course, it's not a very small and it's not a very big one. So what do we think? If there's any fibrocystic changes, you will not find any circumscribed or firm mass, right? If you are considering that 19-year-old girl may be present with the fibrocystic changes that relates to menstruation, but when we are considering fibrocystic changes, those changes should not present with a circumscribed mass. If there is a mass which is a mobile mass and a smooth one, so when it says smooth, you will come to know, okay, that must be a benign thing. But that is only our provisional diagnosis. So mobile term is very important here. The age of the patient is very important in the left quadrant of the left breast. Now, which of the following is the most likely diagnosis? Do you think it's in sclerosis? Is sclerosis in 19 years of age? It is very unlikely. If the patient is like more than 60 years of age, then only you can think about a sclerosis. Because what do we mean by sclerosis? It's a hardened breast tissue, and hardened breast tissue mostly occurring whenever there is a lesion or a prolonged infection, or maybe in the old age when we see the breast masses and the breast tissues are getting hardened. So here, of course, if the breast tissue is hardened, that is not going to give you a well circumscribed lesion appearance. Of course, that will not be the case. So sclerosis cannot be a choice here. Then galactosile. Mostly galactosile is a milk collection. So if she's a married one, she's a fertile, she just delivered a baby, then of course you may think about galactosile, because galactosile, it's a firm, of course, a firm mass typically located in subareolar region. So for the galactosile, this subareolar lesion is also, it's one of the diagnostic clue for you. And most of the time, if galactosile is there, then secondary chances must be that this galactosile is going to be converting to abscess. So when the question says, say for example, the patient is infertile or she just delivered a baby, she's a lactating mother, then you may think about galactosile. But here, who is 19 years, unmarried, firm mass is there, you can never think about galactosile. Now looking at the duct ectasia. So if you can just mute your mic and please unmute whenever you want to ask any question. Okay. So if we are considering duct ectasia, so duct ectasia, of course, it's First of all, whenever duct ectasia is there, now we will always think about, we will always think it's just like a breast cancer. But of course, it's a firm, it's a stable, but it always a painful mass. In duct ectasia, those who are having this ductal ectasia, they will always complaining of this painful mass. And it usually under the nipple, and it may progress to breast axis as well. So duct ectasia will not be a choice here. Why? Because in order to make a diagnosis of duct ectasia, it's okay, it can be there in 19 years old girl, but in making a diagnosis of duct ectasia, that should be a painful mass. That's the best initial presentation for this one. And of course, it's going to be a firm mass, it's a stable mass, and the position will always be under the nipple because it's a ductal involvement. So you will always find, not all over the breast you can find duct ectasia. For the duct ectasia, you will always look for under the nipple. So if under the nipple there is a presentation of firm mass, you can always think about ductal ectasia, and that should be a painful mass. But when it says painless mass anywhere in the breast tissue, and it's a circumscribed, it's a firm mass, and most importantly, it's a mobile mass, like it can move between your fingers, you will always think about fibroadenoma. So here, based on the presentation, you will go for fibroadenoma, and we have excluded all other choices as well. So I think we should go to the next topic. For the next topic, we have to go for the theory. So the next one we have is familial adenomatous polyposis. So it's not there in MTB. So let me take you to AMBOSS. Okay, so this familial adenomatous polyposis, it's an autosomal dominant disorder. Autosomal dominant, it means that if any one of the gene is involved, is having this mutated gene, of course, the patient may present with this condition. So you have to look for a tumor suppressor gene on chromosome 5q22. So that's actually mutation and genetic mutation of this tumor suppressor gene, which is located on chromosome number 22. And this 20-25% cases have a negative family history. So maybe you cannot find, although it's mentioned familial, but sometimes the patient may not present with any kind of family history. So it's not always like that. The family history must be there because it's a mutation in the tumor suppressor gene. Now, polyposis typically develop with the second or third decade of life, occurs in live births. It's okay. Now, very important point, less than 1% of colorectal cancer in the US are due to this one. It means that it has some tendency, although it's a polyp, although it's a benign thing, but it has a tendency to go over a malignant condition, and that is called colorectal cancer. So we should not avoid this condition at all. Although 1%, less than 1% chances there, but it's there. So we should always look for it. And there is no any other thing. The sexes are equal, like male and female both can contract. Most are initially asymptomatic until progression to colon cancer. So if we diagnose, so that's the main reason for colonic cancer, we never get a clue. In fact, the patient never get a clue that he is having this colon cancer as soon as he just started losing weight. So weight reduction is only a clue for these patients, or sometimes there's a history of constipation. Other than that, there is nothing in the patients who have this end stage colon cancer. So that's a very much lethal and very much dangerous condition for patients. So that's why this colorectal cancer screening is very important part. Now, in normal screening, we usually, like the breast cancer screening and the colorectal cancer screening, go hand in hand, because breast cancer also present in the way, and it's a very good prognosis if we can control in early stages. Similarly, colorectal cancer, if it's type 1, 90 to 95% prognosis is there. Or if we just, detect this cancer in later stages, of course, there will be nothing in there. Patient has to die, in 14 and 16 months. Now, what will be the clinical feature here? Altered bowel habit. Sometimes patient may have a constipation, sometimes patient may present with diarrhea. You may find blood in stool, and the patient may complain of abdominal pain. So these are the features of polyp. So if the patient having this polyposis condition, the patient may present with the history. He may say that he's a history of having blood in the stool, he's having abdominal pain on and off. Sometimes he's having this constipation, sometimes having his diarrhea. For the diagnostic point of view, what we will do, we will go for flexible sigmoidoscopy and colonoscopy. Colonoscopy is the best initial one. We'll always go for this one. colon, and you will find on colonoscopy polyps develop in entire colon. The colon will be filled with polyps. Polyps is a finger-like projection. So you will see this finger-like projections all over the colon, always including the rectum. So rectum must be involved here. You cannot find the rectum spared. You will always find the rectal involvement. So all over the colon is polyps, and more than 100 polyps are typically detected in classical familial adenomatous polyposis. So in order to make a diagnosis of polyposis, there will not be only 1 or 2 or 3 polyps. You may find more than 100 polyps in the entire colon. Then only you can say, okay, it's a polyposis condition. So once you do the genetic testing, of course, you will find the mutated gene. So you will come to a conclusion that it's a clear case of polyposis. For the diagnostic point, what we will do, we have to go for prophylactic protocolectomy. Of course, we have to remove that portion of the intestine which has so much polyps. Why we want to do that? Because we don't want this patient to get into a colorectal cancer. So just in order to prevent, the patient getting into colorectal cancer, we have to remove that area. And of course, we will just anastomose the other parts of the intestine together. And we may, and in order to regress the polyps, of course, because there are so many polyps, so you will remove most of the portion who is containing polyp. But if some polyps are left here and there, then we can give the medicines who can just regress the polyps. So for the regression of polyp, we can advise the patient aspirin and the Solendac and the celecoxib. These medicine have a potential. It can, they can help in the regression of polyps. So our main aim should be to remove as much as the polyps we can. But if still some polyps remain here and there, for that we have to give a regression therapy. For the prognosis point of view, the lifetime risk of colorectal cancer is 100% by 45 years of age. So it's very important, like if we are not going to remove this polyps as early as possible, then there is a chance, although 1% chance is there, but that comprises of 100% that the patient can develop this colorectal cancer in later ages of life. So of course, we have to go for always screening for this colon cancer. So now let's have a look at the question here. The question says, a 28-year-old man presented. Now, age of the patient as early as detected, that would be great if we can just detect this polyposis condition in early stages of life. So he is 28 years old with a 2-month history of frequent attacks of bloody stools. So the patient, so for polyposis also, what are the presentations for the polyposis? The patient may present with the blood in the stool. The patient may present with abdominal pain, and sometimes he's having constipation, and sometimes he's having diarrhea. That's a typical presentation of polyposis. Now here, this patient is only complaining of bloody stools. Physical examination was unremarkable. Proctoscopic examination showed multiple rectal polyps. So whenever it says multiple rectal polyps and the patient presented with the bloody stools and the patient is young enough, so you should always think and you should always make a provisional diagnosis of polyposis. Now, when you do the colonoscopy, you find colon and rectum were carpeted with polyps. Not only the colon, not only the rectum, but the entire colon you have seen during colposcopy that it is carpeted with polyps. So there must be so many polyps here. Multiple biopsies were taken. Which of the following is the most likely diagnosis? So based on the presentation of colonoscopy, where the full entire rectum and colon is filled with or carpeted with polyps, and it says the presentation like bloody stool, so always you will go for the diagnosis of polyposis. Why not ulcerative colitis? In ulcerative colitis or maybe in Crohn's disease, the presentation may be like bloody diarrhea and abdominal pain, and sometimes diarrhea and most of the time constipation. But of course, you will not find any kind of polyp there. But instead, you can find fistula formation there. So of course, you can easily rule out. For diverticulosis coli, also you will find diverticulum, especially there will be no polyp history. There will be no polyp you are going to see in colonoscopy. Here, colonoscopy finding is clearly give you a clue that this is a case of polyposis. Okay, for this one, we have to go for the theory. Next, we have this ischemic colitis. For ischemic colitis, I will show in both of these AMPERS and MTB, because some part is there in MTB, some part is in AMPERS 727. Okay, for ischemic colitis, see the word ischemia. Ischemia means that low blood supply or lack of blood supply. We always know very well whenever there is lack of blood supply to any vital organ, to any part, then what will happen? First of all, the patient goes into the reversible ischemia. Reversible ischemia means that right now the part of the tissue is not getting enough blood, but it's still there is a time you can provide the blood and that part of the organ or that part of the body started working. So now still the patient in reversible condition. But once the ischemia goes into irreversible ischemia, there will be no chance if you just provide the blood again to that area, that area is not again going to be functional. Instead of that, that area is going to be more deteriorating condition that is known as necrosis. So that is very important. First, ischemia is reversible, then it will become irreversible, and a state come when the tissue is going to get necrosed or gangrenous. So that's a most important presentation. Now, in ischemic colitis, the word says colitis. So, of course, we will see here the colon especially involved, where the ischemia, where there's a lack of blood supply of the colon, and the colon is getting inflamed, and maybe in all over the intestine. Always remember, whenever it comes for hernia, or whenever it comes for any kind of infection, or when any kind of obstruction in the small intestine or large intestine, there is a time period of 6 hours. If during 6 hours you're not going to release the blood supply to this to the colon, to the small intestine, to the large intestine, there are highly chances of that area is going to be in a irreversible state. So we have only 6 hours time period in order to in order to make that area functional again. Always remember, the 6 hours time period is very important as far as hernias are concerned. Similarly, in hernia, there is a strangulation. Whenever there is a strangulation, there will be a lack of blood supply to that area. And if more than 6 hours are there, that area of the small intestine is not getting blood, then what will happen? There will be a death of all the small intestinal tissues can happen, and that of course that can lead to a death of a patient. So here ischemic colitis is due to a lack of blood flow to the mesentery of the bowel, especially all the bowel. If we are considering the ascending colon, the transverse colon, the descending colon, any part of the colon, any part of the bowel, especially the mesentery, that is a peritoneal covering of the bowel. If there is a low blood supply to that area or lack of blood supply to that area, that can lead to ischemic colitis. So ischemia of the bowel is the most damaging to the mucosa. Of course, bowel has to do a very important function. If you're going to provide low blood or lack of blood to that area, there will be no peristalsis, there will be no, all the food content, all the material will be inside there in the colon, and it will not be, move forward. There will be no peristalsis in that area. And usually it happens most of the time during our clinical practice. We usually see ischemic colitis soon after surgery. That is, most of the time there is whenever the patient is operated for any kind of reason, maybe for, aortic aneurysm surgery or maybe any kind of abdominal surgery. If the patient has undergone any kind of abdominal surgery, after surgery, the patient may present with ischemic colitis. But it's not like that always after post-op. So patient, you will always find ischemic colitis or paralytic ileus. Maybe sometimes the patient has infection, and because of that infection, the ischemia of that area can occur. Now, if we are considering here, what would be the presentation here of the patient who is having this ischemic colitis? First of all, the most common symptoms are abdominal pain, that is described as cramping abdominal pain. So we will find that part of the area who is not getting enough blood. What that is, the patient may present with cramping abdominal pain. The patient may present with bloody diarrhea. Now, why it's so important? Why the bloody diarrhea is there? Because you see, whenever there's a fecal impaction or fecal peristalsis, that is going to exert pressure on the, especially, this impaction material is getting, that area of the bowel is getting more and more under pressure, and because of that pressure, the small vessels, the small capillaries which are forming the plexus over that area, that can burst, and that can lead to a bloody diarrhea. So whenever there is a fecal impaction, whenever there is a peristalsis and there is more and more material inside the colon and it's not getting, forward, it's not removing from inside, then what will happen? The capillary plexus over that area will also get under pressure, and because of that pressure, they can rupture. And because once they rupture, they can just pour, blood outside, and the patient may present with bloody diarrhea. So for the diagnostic point of view, what we will do, the best initial test is CT scan of the abdomen. The most accurate test is angiography. Of course, we want to see what exactly the cause, why the ischemia is there, why that part of bowel or that part of small intestine or large intestine is not getting enough blood. So why? Maybe there is some obstruction in the upper arteries, or maybe some obstruction in the aorta, or maybe some obstruction in the mesenteric arteries or mesenteric veins. Something is there wrong in the vessels. We have to look for, maybe there is some embolus who's going to stuck there. Maybe some thrombus formation is there. Maybe some atherosclerosis is there. Any kind of thing can be there, and that can be easily ruled out on the basis of angiography. When you do angiography, you exactly see the whole blood supply pattern. You will see the whole blood supply pattern. You can easily detect, okay, at this level, at the abdominal aortic level, maybe there is obstruction. Maybe in the middle, in the gut, foregut and midgut, in the hindgut, any point, if the artery is having embolus or thrombus formation, of course you can easily detect. And because of that, the forward part, or the preceding part of the small intestine or large intestine is not getting blood. So we will have a clue, okay, the obstruction is this at this level, that's why this part of the bowel is not getting blood. So of course, first we will go for the best initial test. They are saying is a CT scan of the abdomen. We want to see exactly what is happening there. But of course, you have to go for angiography in order to see at which level the obstruction is there. Colonoscopy with biopsy can also show ischemic mucosa. See, it's not going to add much value to the diagnosis. Why? Because on colonoscopy, or during colonoscopy, if you just take a biopsy of that sample, you just can imagine, or you can see whether the mucosa is ischemic or not, or whether it's a gangrenous or it's a necrosed area. So if there is too much cell death, of course, that area will not be reversed at all. But if there is a chances the patient is reversible ischemia, of course, by maintaining the blood supply again, you will see that bowel will start to function again. But it takes time for pathology to come back. Of course, it will not happen in a jiffy. It will take some time, but it should be very important that you should detect the level till reversible ischemia. If it's irreversible ischemia, then it will take no time to get into the necrosis or gangrenous formation. So treatment is IV normal saline and antibiotic if fever is present. Of course, if the inflammation is there, we have to go for the antibiotic treatment. If the patient is dehydrated, we'll go for the normal saline in order to maintain the electrolyte imbalance. So let's have a look at the question here. No, first let me take you to the AMBOSS as well. Okay. For this intestinal, okay, here, what exactly I want to show you. See, it's mentioned here, a classic case of ischemic colitis is a patient who presents with bloody diarrhea and severe abdominal pain. So the patient who is presenting to you with a complaint of bloody diarrhea, he's having severe abdominal pain soon after surgery. Now, he has undergone this abdominal aortic aneurysm surgery, but any kind of abdominal surgery if the patient has experienced recently, and soon after surgery, post-op patient complaining to you about bloody diarrhea and post-op patients complaining about cramping abdominal pain, then you may think about of this ischemic colitis. Always post-op patient, if presenting with bloody diarrhea, always think in your mind that provisional diagnosis may be of ischemic colitis. And when you do the angiography, when you do the CT scan, it will be clear to you. So, okay. Maybe I should go to the question so that I can exactly see what I wanted to show you in the AMBOSS. So here the question says, a 72-year-old diabetic patient. Now look for the age of the patient. He is too old, 72 years. Diabetic presented to the emergency department with a 2-day history of lower abdominal pain. He is diabetic and he's landing up in the emergency department. He's having lower abdominal pain, nausea is there, vomiting is there, and bloody diarrhea. So bloody diarrhea and lower abdominal pain, look for the age of the patient. Now physical examination confirmed tenderness in the left lower quadrant. So left lower quadrant area is showing tenderness. Now test result normal value, but WBC is increased. So there is infection also, because once the WBC count is increased, it will always give you a clue that there is some infection going on. Now plain abdominal X-ray is showing you thickened descending and sigmoid colon with thumb printing appearance. Okay, I just wanted to show you this thumb printing appearance here. this one. So for ischemic colitis, there is a very important finding here on imaging studies. We will always see an edematous thickening of the mucosa cause indentation in the large bowel. So because of the edematous thickening of the mucosa, you can find in the large bowel there are some indentations, and they usually give you a clue of this thumbprint sign. So this thumbprint sign is very, very particular about, is very particular for, especially for in making a diagnosis of ischemic colitis. So CT wall on imaging studies, if you find this thumbprint sign, you can always think about this ischemic colitis. So that's a very important sign which I wanted to show you here.
Where
Yes.
is the sign?
Huh?
Where is that thumbprint sign?
Thumbprint sign in the large bowel. In the large bowel means
no. Show us the picture diagram.
Diagram. Okay, let me see if I can find here. No, they only mention the mucosa. Maybe we can Google it. Thumbprint sign. So maybe they have mentioned you. They just, or maybe it's also clear here. Okay, just have a look here. There are actually multiple air fluid levels. Can you see? Can you appreciate here the multiple thumb impression signs are here? So actually it's showing you that these are, what is this actually? Some part is working and you can find some air levels and multiple air levels. So these multiple air levels are actually giving you this clue. Or maybe here also you can appreciate, but it's like this one, upside down. Here also. The different pattern you can see because it's an air fluid level. So what kind of air fluid level is there, you can find in that way. So it's very much clear here. See these thumbprint signs. So it's showing you that this part of the because of this air fluid collection, what we can think that some part is having less blood supply and some part is having this distension before and distension after, and here you can find multiple air fluid levels.
Okay.
Here also you can see. So let's get back to this one. So just remember this point. If you see on imaging studies, this thumbprint sign, so you should always think about this one. And presentation, of course. First of all, the presentation is bloody diarrhea, presentation is abdominal pain. And then once you do this imaging studies, if you find this thumbprint sign, that can lead to a diagnosis. So getting back to the question, here the question up till now, it's very clear. Bloody diarrhea was there. The patient was having WBC count is increased. Of course, it's a colitis condition, so you will find increased WBC. And a plain abdominal X-ray we just saw that's showing the thumbprint appearance. So this thumbprint appearance is very much particular with ischemic colitis. Because thumbprint sign, you are not going to see Crohn's disease. Crohn's disease, you may find some fistulas, but that has to be that, and for histological point of view, you can easily clear, not only on the basis of this one. Based on the presentation, bloody diarrhea, you may think about Crohn's disease, but of course, thumbprint sign is not going to be seen in any kind of this one, not in acute diverticulitis, not in Crohn's, not in ulcerative colitis. So once it's clearly mentioned about the X-ray finding, you can go for ischemic colitis. For the next one, we have to go for the theory first. We have this hemorrhoids. Again, hemorrhoids will cover from both because some part is not there in MTB 753. Okay, for hemorrhoids, they're saying hemorrhoid veins are normal in active structure located in the submucosa layer of the lower rectum that enlarge, and any of the multiple factor can cause enlargement. So actually, these are the veins. These are the normal anatomical structures, but sometimes they get enlarged. these veins, these hemorrhoidal veins, when they get enlarged, they will give you an appearance of hemorrhoid. So any of multiple factors can cause the enlargement. So what are the factors that can cause enlargement of the veins, enlargement of the hemorrhoidal veins? That can be constipation, that may be an advancing age, that may be a prolonged sitting posture, although it's not a pathological cause, but it's there. It's straining, too much pressure, coughing during defecation, that can all lead to dilatation of the hemorrhoidal veins. So especially whenever there is hemorrhoidal veins dilatation, you can say it's a hemorrhoid. Among patients with hemorrhoids, 40% are asymptomatic, but the most common symptom is bleeding. So whenever the patient complains to you that he is always having bleeding in stool during defecation time period, always think about hemorrhoids. So patient may also report itching, burning and pain, but most of the time the presentation is always bleeding per rectum, especially during defecation, during passing stool. Now diagnosis is made clinically, but the most accurate test is endoscopy. Of course, you can go and direct examination of the anal canal will give you a clue whether the veins are there, dilated or not. The initial treatment is with dietary modification. We'll ask the patient because of the straining, because of the constipation, it usually occurs. So we'll ask for the oral hydrations to softener, increase fiber intake diet, so that the patient is not ending up in constipation. In conjunction with sitz bath and topical steroid, if too much inflammation is there, too much pain is there, we can go for topical steroids. If conservative measures fail, rubber band ligation of internal hemorrhoids is indicated. So we'll look for the presentation of the hemorrhoids, internal and external, and we will do that. We will do the management on the basis of that one. So let me pull one diagram for you. I have taken this from Ambos. It will give you an exact clue how we are going to manage the patient who is presenting with hemorrhoids. So symptoms of hemorrhoids, if are there, it means that the patient is presenting with bright red bleeding, the itching is there, the burning is there. The patient is typically saying that when I'm passing stool, I can exactly see the bleeding is there. So that's a clear cut clue for us in making management of hemorrhoids. Now what we will do? We will do the perianal inspection and digital rectal examination. That is the first thing we will do. Now, upon inspection and upon digital rectal examination, if there is inconclusive result, we cannot find anything, like there is no clear-cut evidence, because most of the time these hemorrhoids are internal, and they usually, the veins are dilated during the time of defecation. So sometimes the patient may present in lying position, maybe sometimes you cannot appreciate that thing. So then you will go for endoscopy and proctoscopy, and when you pass the scope and you see exactly what is there, then you will see, okay, above the dentate generally painless. Now you have to say, now here on perianal inspection, of course, if the hemorrhoids are visible, you can say it's external hemorrhoids, because there are the dentate line sometimes painful. So dentate line is especially, a margin on the anal canal that will give you a clue. So whoever hemorrhoids are there, which is below the dentate line, it means that they are there. You can easily see on naked examination, on eye examination, on rectal examination. If you can feel the hemorrhoid, or if you can see the hemorrhoid, that is external hemorrhoid. But if you cannot see the hemorrhoid, then you have to go for the endoscopy, and only on that you can see the hemorrhoid which is inside or above the dentate line. You can say it's an internal hemorrhoid. So external hemorrhoid, it's quite obvious, it's quite visible because it's below the dentate line. But if it's above the dentate line and we cannot see on the basis of rectal examination, finger examination, we have to go for the endoscopy. Then only we can say it's an internal hemorrhoid. And sometimes, if there are inconclusive results, we always have to go for colonoscopy, just in order to see whether there is a malignancy who is presenting with this bleeding per rectum, because most of the time malignancy also present with bleeding per rectum. So of course we have to go for colonoscopy. If we cannot find anything, we cannot find external hemorrhoid, we cannot find internal hemorrhoids. So external hemorrhoids, it's very much obvious based on the perianal inspection, based on the digital rectal examination. But of course, in order to see internal hemorrhoid, they are internally present. So we have to go for endoscopy. Now for internal hemorrhoids, For external hemorrhoid, what we can do, we can only go for the conservative treatment. Conservative treatment means that we just ask the patient for the lifestyle modification. We ask the patient to go for stool softener, sitz bath. That's the important thing. If still the symptoms are there, then we can ask the patient to go for non-surgical outpatient procedure. Like you just, tie a rubber band around that area, that is called rubber band ligation, or maybe we can go for sclerotherapy, or maybe we can go for infrared coagulation. These all procedures can be done in OPD basis. So they are called non-surgical outpatient procedures. But if still the symptoms are there, I'm talking about this external hemorrhoid, then we can go for surgical treatment. That is hemorrhoidectomy you can perform. But what if we are considering internal hemorrhoids? For internal hemorrhoids, we will always consider 4 types. There are grade 1, grade 2, grade 3, and grade 4 internal hemorrhoids. If grade 1 and grade 2 means that these are not prolapsed, that's why they are not visible, they are not easily appreciable outside. Outside the anal canal, you cannot see them. So they are called not prolapse, grade 1, and reduce at rest, grade 2. Means that if the patient is in resting condition, you cannot appreciate these hemorrhoids. So of course, if grade 1 and grade 2, again we will ask the patient for conservative treatment. If not, we will go for non-surgical treatment. If not, we will go for surgical treatment. But if the hemorrhoids are there, internal hemorrhoids, and they are reducible, manually reducible, like the patient by himself can reduce them, and when you do the examination, if you just you can also reduce those hemorrhoids, like by pressing, it can be gone completely. So it means that they are manually reducible. So for that also, of course, we will not go for conservative treatment. We will just go for non-surgical. We will just tie the rubber band. We will go for the rubber band ligation. We will go for the sclerotherapy. Maybe we can go for the infrared coagulation. If not, then surgical treatment. But these hemorrhoids, which you can see, they are non-reducible at all. They are thrombosed, very much thrombosed. They are very, very hardened. You can see exactly the reddish hardened hemorrhoid is there, and that is not reducible at all, irreducible. You can say it's a grade 4 hemorrhoid, and for grade 4 hemorrhoid, we cannot do anything. Only the surgery is the curative therapy. We'll go for arterial ligation, we'll go for hemorrhoidectomy, we'll go for hemorrhoidopexy. So just remove the hemorrhoid. That's the only thing we can do for grade 4. So let me take you back here.
Excuse me, Dr. Hira?
Yes, dear.
Where will be the line to demarcation between external and internal hemorrhoids?
Yeah, you want to see the dentate line? I will show you. I will show you. Yeah, I will show you. I will show you that dentate line. But first, just finish this theory, and then I will take you there. So this hemorrhoid location, see in MTB also, it's very clear for you. You can easily cross from this side. External hemorrhoid means distal to the dentate line. Means it will be below the dentate line, so that you can easily appreciate. And internal is proximal to the dentate line. It must be above the dentate line. I will show you this dentate line. Now see here, acutely thrombosed external hemorrhoid can be treated by excision. We have already done this one. Acute thrombosed hemorrhoid is which grade? That must be a grade 3 and grade 4. In grade 3, still there is manual reduction, but in grade 4, it's always a non-reducible, irreducible thrombosed hemorrhoid. I want to show you here also hemorrhoids. Yeah, so see, it's very important for our exam point of view. Always remember, whenever the patient is more than 40 years of age, okay, any kind of hemorrhoid is there. You know the management part. You know that we can go for non-surgical treatment. First, we have to go for conservative treatment. Then we have to go for non-surgical, and then we have to go for surgical. A part of this management, whenever the patient is 40 years of age, more than 40 years of age, you will always do colonoscopy in that patient. Just be on safe side, just to rule out the malignancy, because whenever there is defecation, bleeding is there, we can always think about malignancy. No doubt you can easily find the hemorrhoids if you have already seen the hemorrhoid, but sometimes hemorrhoids can be in a concomitant with malignancy. So we, by just saying that hemorrhoids are there and the patient does not have any malignant cancer, colorectal cancer, that cannot be ruled out. So always please remember, whenever the patient is complaining of bleeding per rectum and he is more than 40 years of age, no doubt we have to go for this for the management of hemorrhoids if there are hemorrhoids. But apart of that, you will always do colonoscopy just to be on safe side. Anyhow, 40 years of above 40 years of age, colorectal cancer screening is common. So we can counsel the patient that it's on your it's on your betterment that we have to go for colonoscopy just in order to rule out malignancy. Although we know the clear cause of bleeding per rectum is hemorrhoid, but just to be on safe side, we should always perform colonoscopy. That's a very, very important thing. So that's the thing which I wanted to show you. Now here I will show you dentate line. So maybe this one, because that's an anatomical thing. See, these are the dentations. Can you see these dentations? These are called dentate lines. That's you can only find on cross section of this anal canal. So the one who is above this dentate line, of course, that will be an internal hemorrhoid, and the one who is below this dentations, that will be a external hemorrhoid. So external hemorrhoid you will always find here, somewhere here, and the internal hemorrhoid you will find here. Okay, so these dentations is a histological dentation that is called dentate line. So now go back to the questions. Here the question says, a 66-year-old healthy man complains of rectal bleeding.
Dr.
Now,
Hira,
yes, dear.
this dentate line can be appreciable with naked eye?
It can be on rectal examination. When you pass your finger and you check, you do the rectal examination, you can just imagine, you can see the dentations. That's a normal thing during rectal examination.
These are palpables,
Yeah.
huh?
Okay. Yeah. Or anoscopy, of course. During anoscopy, you can easily see through your eyes because you are introducing an anoscope. But fingers also you can easily appreciate. But of course, it will require some expertise. You should do many more rectal examinations, then only you can feel the dentate lines.
Yes, yes, yes.
Okay, so a 66-year-old healthy male. See, the age of the patient is very, very, very important. He is 66 years, so more than 40 years. Okay, remember the point. Now, man complains of rectal bleeding for 3 months. So, rectal bleeding in a 66. If I'm going to solve this question just by reading this first line, I should always think about colorectal cancer. Because whenever we say a postmenopausal women is presenting with the postmenopausal bleeding, you will always think about cancer, right? Until proven otherwise, similar cases here. But of course, we have to complete the whole question in order to clear this one. Anorectal examination confirmed 3rd degree hemorrhage. So you have a definitive diagnosis in your hand. This patient is having 3rd degree hemorrhoid, but he is 66 years of age. Now, which of the following is the most appropriate next step in management? You know very well, the 3rd degree hemorrhoid is still a manual reducible hemorrhoid. We may go for band ligation, we may go for sclerosing, we may go for infrared radiations. That is the non-surgical treatment. And if it still persists, we'll go for surgical option. But here, they are asking you which of the following is the most appropriate next step in management. So what you will do, are you going to go for colonoscopy, or you will go for hemorrhoidectomy, abdominal computed tomography, or submucosal injection of a sclerosant? So what do you think? If anyone, if Dr. Taira?
Colonoscopy.
Why you are going for the colonoscopy? Very good. Because
of suspicion of
malignancy, exactly. Colorectal cancer. This answer is also right. See, question of this choice D, submucosal injection of sclerosing. That is also right, because that's a sclerosing agent. We can introduce this one also, but that is a part of the management of particularly hemorrhoids. But here we are more concerned about in order to rule out malignancy based on patient's age. That is very, very important. So we'll go for colonoscopy option. Okay, this one. A 20-year-old patient complains of painless.
Dr. Hira, even they have given in the diagnosis of grade 3 hemorrhage, but still we will do colonoscopy to rule out pregnancy.
Yes, yes, exactly. Because the obvious source is there. Like third-degree hemorrhoid, of course, it will present with the bleeding. But in 66-year-old, this cannot only be the reason of bleeding. So we have to rule out the other reasons as well. And that's very much obvious that we ask the patient to go for colonoscopy in order to rule out malignancy. That should be your
So
next
here
step.
they're asking about the best next step in the management. If they ask the
Yeah.
appropriate next step for the treatment, then we will go for colonoscopy.
Yeah, of course, of course. Then you will go for band ligation therapy. If band ligation is not in the choices, we'll go for sclerosing agent, we'll go for infrared. Exactly. Okay. Now this one, a 20-year-old patient complains of painless, fresh bleeding. Now, he is just 20 years old. Complains of painless, fresh bleeding post defecation. So once he passed through, he finds this painless, fresh bleeding over the last 6 months. Now, which of the following is most likely diagnosis? So of course, he is having this post defecation bleeding. He's just 20 years of old. So you will always think about what should be a most likely diagnosis. See, anal fissures. Anal fissure will always be a painful thing. It cannot be a painless bleeding because there is a fissure, right? So whenever there is a fissure, whenever the patient is going to pass through, that must be a painful procedure. So of course, anal fissure cannot be a choice. Although anal fissures do bleed as well, anyhow, the bleeding through hemorrhoids and bleeding through anal fissure, there will be a hell of difference. For the 6 months time period, you cannot find too much bleeding in case of anal fissure. But of course, for hemorrhoids, the patient may present with anemia condition also. Perianal fistula, you cannot say, only on the basis of bleeding, you cannot, anyhow, fistula sometimes will not present as a bleeding thing. There will not be any bleeding at all, but you cannot see only on the basis of symptoms that this is fistula. You have to go for the examination. Perianal abscess will always be a painful, very painful. So here it's clearly mentioned painless, so you will always go for
Hemorrhoids. Dr. Hira, where the perianal fistula will open?
Perianal fistula, the same anal canal, but it's of course it's it's around the anal canal, but of course the fistula is going to open into the anus. So it's anus and it's going to enter into the mucosa and submucosa. It's going deeper and deeper. So it will make a clear path. You want me to show you perianal fistula? Sure.
No, Dr. Hira?
Yes, dear, your voice was breaking out. Tell me.
Can you hear me?
Yeah, now I can hear you.
The fistula will be opening in the anal mucosa and anal canal, but from where it will be starting, from the mucosa?
Yes, it will be starting from mucosa, and then it will go into the mucosa. Let me show you this diagram.
Okay, show us the diagram.
Can you see? I'm searching here. This one is not very much clear. Maybe we'll go for this one. See there, here you can see. No, it's very not much clear here as well. If you can just see with the help of these lines, they have actually mentioned you a clue that this is perianal. Around the anus, there is a clear cut opening between this area. Like it's in combination here. No, it's not very much clear here. Let me take out something other diagram. See, if you can just see here, it's showing you perianal abscess also. So this abscess can lead to perianal fistula, but again it will lead to perianal fistula. Anyhow, see, for perianal fistula, there should be you want to ask you actually where exactly the openings will be. Like fistula has two openings. So one opening should be in the anal canal and one opening should be in the subcutaneous area of this one. Subcutaneous area behind the rectum, behind this one area.
Okay, okay.
So there should be a combination. There should be a clear route between this subcutaneous area and this rectal area through anus. So anus and this subcutaneous area will be through and through. So that will be a fistula. And because it's towards the anal side, that's called perianal fistula. So they just mention
Okay.
everywhere like this, yeah. So there will be a clear cut. There will be a clear cut through and through channel between subcutaneous area behind the rectum and this anal area. So they will be together.
Dr. Hira, there's a diagram showing the anal fistula, fissure, and
This one?
fistula. Yeah, this one, the anal fistula,
Yeah.
fissure, and abscess.
Yeah. So just look here. So again, there is one line here. So I wanted to show you exactly the subcutaneous area where we can see the things through and through. But anyhow, you can see here also subcutaneous area is this one, and this is the anal area. So there's a clear channel in between here. So that's a fistula. Of course, these are the fissures you will find here. And if there is inflammation, something here, you can say it's anal.
Fistula. Okay, one opening will be in the mucosa anus, and the other will be in the outside inside
in the subcutaneous area.
Subcutaneous.
Exactly.
There will be a canal. Made a canal.
Yes, because for fistula always there will be a two-way channel. If it's one-way channel, it's called diverticular.
Yeah. Thank you.
So let's get back here. Okay. So for the next one, we have to go for the theory first. Next, we have this pancreatic cancer. So for pancreatic cancer, I need to show you two things, two pages here in MTB. One is 81. So for pancreatic cancer, see pancreatic cancer, it's a very, again, it's just present like, colonic cancer. Soon after the diagnosis, the patient has, very limited time period. The prognosis is very poor. It's just started and, just going to end the life of the patient. So the time period for the treatment time period will be very less. So most of the time asymptomatic, and once the symptoms started, it's already, ended up into a very advanced stage. So for pancreatic cancer, look for the patient with painless jaundice. Whoever the patient, age doesn't matter, may present with the painless jaundice. The jaundice is there. The history of weight loss. Of course, whenever we are considering cancer, cancer will always be painless. Tumor will always be painless, and tumor always associated with weight loss history. The patient must be in caxic state, like the state where the patient is losing weight day by day. So the weight loss history is there, and generally non-tender epigastric area. The patient may present with the pain in the epigastric area, but that will be a non-tender area. There will be no inflammation and no tenderness there. So these three signs are very important. Whenever you are looking for pancreatic cancer, or you are excluding pancreatic cancer, you will always look for the jaundice. If the patient is having jaundice, if the patient is having a history of weight loss in 1 month, 2 month time period, 3 month time period, 6 months time period, and must be epigastric pain, then you will always think about pancreatic cancer. Now, amylase and lipase are mostly normal, while bilirubin, alkaline phosphatase, and GGTP are elevated. So that's again a very important clue for us in making a diagnosis. These lab investigations, you may find amylase, lipase normal, but you will always find, because jaundice is there, you will find high level of bilirubin, you will find alkaline phosphatase, liver enzymes, GGTP also elevated. So that's a laboratory lab investigation part. There you can easily make a diagnosis. For the diagnostic testing, when we go, yes, dear.
Please, can you elaborate? Amylase and lipase will be high in which?
Yes. Yeah. See, amylase and lipase, these are the particular enzymes which are actually called pancreatic enzymes. So, of course, see, whenever we are considering about these enzymes, or they are the digestive enzymes, but they are actually forming inside the pancreas, and they have to be released through the pancreatic duct and enter into the duodenum. So if it's a tumor, you can think about whenever there is a tumor, there may be an increased number in size, of increase in number of cells. So you may think about that these amylase and lipase can be high. In normal condition, we may think about like that, because this pancreatic especially if you are considering carcinoma, the increased number of cells will be there, and the enzymes which are formed through the cells can also be increased in size. But normally in this pancreatic cancer, we will not find, because these amylase and lipase, amylase are actually act on the carbohydrate portion and lipase act on the fat portion, and the main mechanism of these two enzymes is it's digestion, carbohydrate digestion and the fat digestion. So they are not only produced in the pancreas, but they are also produced in the liver as well, these enzymes. So what we are talking here, that amylase and lipase usually high whenever there is a liver pathology and whenever there is a pancreas pathology. But whenever we are considering only about the pancreatic cancer, pancreatic carcinoma, so in this carcinoma, we usually find these levels normal. Why? If there is normal pathophysiology, if there is normal physiology, so we should know whenever there is increased number of cells, that cell, of course, can also produce more and more amount of amylase and lipase, but it's not happening here. Why? Because the main feature in carcinoma here, it's not only about this one, but here there's some autoimmune reactions take place where our own antigen is going to, our own antibodies is going to act on these enzymes, and they will be, there will be a phenomenon of own destruction of these enzymes, because there is a pathology here. So always remember that these amylase and lipase, they are not only secreted from the pancreas, but they're also secreted from the liver, but they're the main enzyme of pancreas. But by simply saying the pancreatic carcinoma, we may find some autoimmune reactions here, thereby the overall number of amylase and lipase you are not going to see high. But of course, the other thing, like bilirubin, why the bilirubin is high? Because this bile is actually secreted from the gallbladder. That's not secreted from the pancreas. But of course, pancreas, the duct from the pancreas and the duct from the gallbladder is going to combine it, and it will form hepatic duct. Ducts are also coming from the liver and the gallbladder, and it will combine with the pancreatic duct, and it will form this hepatopancreatic duct, and it will open into the duodenum. So the whole duct systems are actually combined together. But overall, what we will see here most of the time, because of the pancreatic cancer, pancreatic carcinoma, they will getting increase in size, they will become larger and larger, and they will obstruct the duct, especially the gallbladder duct. So when they obstruct the cystic ducts of the gallbladder, what will happen? The more and more amount of bile is getting into the gallbladder. The normal phenomenon of gallbladder is this one: it has to store the bile for 8 hours. After 8 hours, it has to release the bile, because the gallbladder function is, it has to just carry the bile. Bile is actually forming in the liver, but that bile has to be there and remain in the gallbladder for 8 hours. And after 8 hours, it has to be secreted. And not only during 8 hours, if it in between the patient eats any kind of fatty things or fatty meal, what will happen? Cholecystokinin is activated, and cholecystokinin is going to, go and act on the gallbladder and ask the gallbladder to secrete bile. So that's why we will usually see whenever the patient eats, what happens? The cholecystokinin is activated, and that is going to activate the gallbladder, and the gallbladder contracts, and the gallbladder release the bile. But what if there is pancreatic cancer? That growing mass of the pancreas is going to obstruct the gallbladder duct, and what will happen? That bile is going to be inside the gallbladder, and it will retain there. And of course, the bile is not coming from the gallbladder. It's only stored in the gallbladder. The bile is coming from the liver, and liver is also going to give its bile directly into the duodenum. So the patient may get bile from the liver, but of course not from the gallbladder. So you will find increased number of bilirubin because of the obstruction in the bile duct, especially the gallbladder duct. And why it is all happening? It is all happening because of pancreatic mass. This pancreatic mass is obstructing the duct, especially the duct of gallbladder, obstructing that particular area. You may find distended gallbladder, filling of too much amount of bile because of the mass who is just there on the neck of the gallbladder, on the neck of the duct of the gallbladder. Because you know the anatomical position of pancreas.
Yeah. Okay, sorry. In the acute pancreatitis, lipase and amylase is raised.
Yeah, because that's an inflammatory markers that they are going to increase in, they are the inflammatory markers. In response to the inflammatory markers, the enzymatic, secretions will be high. So in that case, you will find increased levels. Yes. But here, because of the autoimmune reaction, you will find decreased levels. So here now,
yeah. And how alkaline phosphatase and GGTP are raised?
That's at the liver. Those are the liver apoproteins, of course.
So they will be raised due to obstruction.
obstruction. Exactly.
Okay.
Now, CT scan reveals the pancreatic mass. Of course, whenever there is a pancreatic tumor, you will find mass in the pancreas. So that mass can be easily detected on the pancreas. 90% of the time, you can easily see the mass in the pancreas. So whenever we say the patient who is having a history of weight loss, the patient is having jaundice, the patient is depressed because of this sudden decrease in the weight loss, you will always find that this is a case of pancreatic cancer. But of course, if you cannot find mass in the pancreas, the CT is negative. The next step is endoscopic ultrasound with the biopsy of the pancreatic lesion. So whatever the lesion in the pancreas, you have to go and take the biopsy of that lesion in order to see what is happening. And maybe it is in the started in early ages, early time period, and you may find in the later time period that the mass is there. If CT shows a clear lesion in the pancreas, the next step is surgical biopsy. Of course, whenever you find anything, any suspicious thing in the pancreas, you have to go for it. If mass is there, that easily give you a clue that tumor is there. But if mass is not there, a lesion is there, which is just started and can proliferate in, very soon, you have to go and take a biopsy. That thing you should see whether that lesion is malignant or not. So of course, it's a cancer. We'll go for chemotherapy and radiotherapy. The survival rate is very low, 5% in 5 years. The prognosis is very poor. Let me take you to Ambrose also. Here, you will always see abdominal ultrasound where this sign is very important here. This double duct sign. Double duct sign is what? Because of the increasing size of the pancreas, you will find that this increased mass is not only going to block the common bile duct, but it's also going to block the pancreatic duct. So when you do the imaging studies, you will find the two very dilated ducts. So that is a peculiar sign for pancreatic cancer because of the increase in pancreatic cancer size, pancreatic tumor size, increase in the pancreas. Pancreas is not only going to obstruct its ducts like pancreatic duct, but it's also going to obstruct the common bile duct, and you will see the two dilated ducts on examination. That is a clear clue that's a pancreatic cancer. So let me show you the question here. Here the question says, a 67-year-old man presented with 2-month history of yellowish discoloration of his sclera. So he is 67 years of age. He's having yellowish discoloration of his sclera, means jaundice is there, and skin with dark urine and pale stool. He lost his weight in past 3 months. Since then, he's feeling depressed most of the time. So 3 months, weight loss history is there, depression history is there, jaundice history is there. So triad is there. In order to make a diagnosis of pancreatic cancer, there should be a triad. You remember the triad? Depression, jaundice, weight loss, and all the things are here. On examination, alkaline phosphatase is high, direct bili is high, total bili is high. On ultrasound showed mass in the pancreas. So now the clear thing is there with you. Mass in the pancreas and double duct sign. So whenever we say double duct sign, you can easily relate to the mass because this is the mass who is going to obscure the pancreatic duct and the common bile duct and giving a dilatation appearance of these ducts on imaging studies. So which of the following is the most likely diagnosis? Based on the lab investigation, based on the symptoms, you can easily say this is a case of pancreatic cancer. Here there is, maybe we can put Mersey's syndrome here because that comes in the differentials of Mersey. Yeah, the spelling is correct. Okay. So if we just rule out this one, clad skin tumor, you know what is this clad skin tumor? It's a cancer. It's a cancer that develops in the cells that line the bile duct, especially if there is a cancer in the bile duct where the right and left liver ducts meet, we can say it's a tumor. It's a clad skin tumor. So in simple terms, you can just remember that's a tumor of the bile duct. The cells of the bile duct, if they are become cancerous, that's called clad skin tumor. But of course, if there is a bile duct tumor, you cannot find mass in the pancreas. So of course, we cannot make a diagnosis of this clad skin tumor. In Mersey syndrome, what is there? It's a common hepatic duct obstruction. So whenever there is a common hepatic duct obstruction, maybe because of any extrinsic compression, most likely a stone, an impacted stone is there, and that can cause a common hepatic duct obstruction. then we can say it's a Mirosi syndrome. But of course, you will not find any pancreatic mass in that case. So we cannot make a diagnosis of this one. And common bile duct stone, of course, there will be a duct in the common bile duct. It can give the jaundice, but of course, weight loss history and of course, the pancreatic mass cannot be there in the choices. So of course, the clear-cut history is pancreatic cancer. For the next one, we have to go for the theory first. Next, we have paralytic.
What do you told? What is Mirosi syndrome?
Mirosi syndrome is a common hepatic bile duct obstruction. Obstruction mostly at the level of common hepatic bile duct due to a stone impaction. So whenever the stone is going to impact it in the common hepatic duct and it's going to cause the obstruction in the common hepatic bile duct, that is called Mirosi syndrome. The patient can present with the jaundice, of course.
Attacking inside the bile duct.
Yes, of course. But of course, that patient cannot present with the pancreatic mass and all that. So it can be a DD of jaundice, but of course, it cannot be a DD of pancreatic cancer.
Okay.
Then we have this paralytic ileus. For paralytic ileus, I will take you to members. So paralytic ileus is a functional bowel obstruction or a dynamic bowel obstruction in which there is bowel obstruction and it's not moving at all. Not moving means that there is no peristalsis. So most likely, always, most of the time you will see in post-operative patients, the patient may go into the paralytic ileus, the ileus, the small intestine, and the bowel is not recovering from the anesthesia most of the time. But again, it can be because of infection and all that. So paralytic ileus, also called functional bowel obstruction, is the interruption of the normal passage of bowel contents due to reduced peristalsis. So that reduced peristalsis may be because of absence of mechanical obstruction, maybe because the anesthesia is too much for that particular intestine, it's not recovering at all. It is often transient. Of course, it will be a very less period of time. It should not go beyond 6 hours. You remember, right? Why it should not go beyond 6 hours? Because once it's go beyond 6 hours, it can be in an irreversible state and it can lead into necrosis and gangrenous of that area. So it is often transient. Perioperative ileus is one of the most common. Post-operative ileus is one of the most common cause of paralytic ileus. Just now we did this one. Other etiologies, maybe the inflammation, maybe the some retroperitoneal visceral inflammation, some metabolic disturbances. Some medications can also cause mesenteric ischemia, low blood supply of the mesentery can also be a cause of paralytic ileus, but most commonly you will always find in post-op patient they usually go into paralytic ileus. So paralytic ileus typically manifests. Now how the patient is going to present? Of course, there is no peristalsis. If there is no peristalsis, the patient may present with nausea, vomiting can be there, abdominal pain can be there, distension will be there, the intestine will getting distended and distended, constipation will be there. There will be no passage of stool. And what is the very, very obvious thing? When you heard, you hear the gut sound, there will be no gut sounds. So if there is no gut sounds after operation, for about 4 hours after operation, 5 hours after operation, 12 hours after operation, there are no gut sounds, always consider this paralytic ileus. Okay, so this one. Now, the characteristic imaging feature of paralytic ileus is diffuse dilatation. When you do the imaging studies, you can exactly see the dilated bowel loads. You will see air fluid levels. You will go for the lab investigation. You will find here lab studies can be useful to identify the underlying cause to assess for complications. So if there is infection, of course, you will find increased amount of WBCs. If there is ileus, potassium will also be very low in that case. Apart from treating the underlying cause, there are few specific treatment measures for paralytic ileus management. Of course, will be a supportive one. You can go for fluid resuscitation. If there are electrolyte imbalance, you will go for that. Surgical intervention is indicated if necessary. If there are complications, complication means that if there are chances of getting into the irreversible ischemia, then of course we have to go for surgical intervention. So acute colonic pseudo-obstruction, also known as Ogilvie syndrome, is a distinction clinically. So it's Zesta syndrome, where you can see typically affects critically ill or post-operative patients. So whenever there is acute colonic pseudo-obstruction, just present like pseudo-obstruction, but it's not there. Like paralytic ileus, there is no mechanical obstruction to passage of bowel content. However, the risk of severe colonic dilatation and potential perforation ischemia is significant. So just remember for this Ogilvie syndrome, sometime post-operative patient, they just present with acute colonic pseudo-obstruction. It's a pseudo-obstruction. So just, after some time when the patient get mobilized, this will go off. So that's a temporary thing we can say. It's a syndrome they have mentioned here. But of course, if it's perforation, if there is ischemia, it can lead to necrosis. So clinical features, we have just did this thing that the patient may present with constipation, nausea, vomiting, abdominal distension. For the diagnostic point of view, you will go for especially you will go for imaging studies, you will go for the abdominal x-ray, you will see dilated bowel loops. That's an important thing for imaging studies to rule out, especially this one. Of course, if there is infection, we have to go for the lab investigation. Say, for example, we should know the underlying cause. If there is appendicitis, cholecystitis, that can also present with paralytic ileus, but it is very less likely. The abdominal ultrasound will show fluid-filled dilated bowel loops. So, of course, whenever there is ileus, paralytic ileus, you will always find dilated bowel loops. Like in this one, you can easily see here. You can see this normally, these are too much dilated bowel loop area. This is the feature of ultrasound. When you do the imaging study like abdominal x-rays, that will clearly see, you will clearly see your fluid levels in there. On ultrasound, this bowel loop is so much dilated as compared to the normal one. So x-ray abdomen, you can see here. You see there are too much air inside. That's showing dilatation. Here also see too much air fluid levels. It's showing dilatation. Here also too much dilatation, too much air fluid levels.
Yes, yes, yes.
Here also too much air fluid. It's a lying posture. Here also you can appreciate blackish areas showing air. So of course, when you do the routine workup, if there is inflammation, CBC count, you will see high WBC. If you go for this, of course, if renal functions are compromised, you will find increased urea, increased creatinine. Potassium will be low. That's a very, very clear finding in these paralytic ileus patients. Magnesium will be low, potassium will be low. That's the most important thing. Other than further studies, it's okay. We are not go for that one. For the treatment part, what you're going to give for this patient, evidence-based recommendation management is mainly conservative. So you will just give IV fluid, you will just bowel rest is there, early mobilization of the patient should be, if there's a post-operative patient, go for the early mobilization. Okay, these are for the conservative management. Initial measures for all patients, we will just initial bowel rest. So how you will do the bowel rest? You will just ask the patient not to take anything orally, nothing per oral. That is the supportive treatment. So you will not give anything. You will just give the IV fluids. You will just replace the electrolyte. You will put your patient on oral analgesic. If the nausea feeling is there, you will just advise oral antiemetics or maybe IV antiemetics, a good choice. Nasogastric tube insertion, too much air fluid level, you have to decompress the bowel. So of course you will go for nasogastric tube insertion. You just monitor the patient. You will give them laxatives, you will give them prokinetics, for the bowel movement. You will go for the treatment of opioid-induced ileus. Consider the addiction of peripherally acting. Now this one is only for those who are already addicted one. But of course not every patient is a addicted one. Surgery can be there. Surgery, of course, if there is underlying cause, say for example, appendicitis is the main reason, we'll go for this one. If there is intestinal ischemia or perforation, we'll go for the treatment for the surgical option. And here I just wanted to show you the complications for, no, there is no such complication. Complication, there may be chances of aspiration because of because of vomiting. The patient may there may be a chance of aspiration. The respiratory compromise will be there. There may be too much hypovolemia. There may be ischemia, necrosis, and that's a very obvious thing. Like if persists for more than 6 hours, necrosis can be there. Peritonitis, sepsis can be there. So these are general complications. So let's have a look at the question. Here it says a 28-year-old is 4 days post exploratory laparotomy for a perforated acute appendicitis. So he was operated. He was a case of perforated acute appendicitis. He was operated already. Now it's a 4th day and is complaining of generalized abdominal discomfort and vomiting. Now overall he's having a feeling of this abdominal discomfort. He's having vomiting. Physical examination confirmed a distended abdomen. So distended post-op distended abdomen, you should always think about paralytic ileus. Mild generalized tenderness and sluggish bowel sounds. Bowel sounds are there, but they are sluggish. That's why the patient is having vomiting. WBC is 12.5, so it means that inflammation is there. When you do the abdominal X-ray, you will see multiple layer of fluid levels. So whenever there are multiple layer of fluid levels after post-op, always paralytic ileus should come in your mind. So of course, that's a clear case of paralytic ileus. Okay, the next one, we have to go for the theory.
Hira, what was the addiction you were telling?
Addiction is opioid. Those who are taking opioids or those who are taking morphine, like they are the drug addicts. In those drug addicts, there are mostly, post-op, they are ended up in this problem. Why? Because their intestines are usually prone towards that opioid. Or maybe sometime during post-op when the patient is too much in pain, we usually give painkillers. But if we give too much high doses of painkiller, too much opioids, then what will happen? As a painkiller you are giving opioid, that also cause paralytic ileus, because gut will be in anesthesia state and it will not be reversed. So once it will not be reversed, it will end up in paralytic ileus. Yes. That's why sometimes too much anesthesia can also cause. Sometimes the patient are receiving KINs. These are considered to be opioids. So if they are receiving opioid because of, as a painkiller you are giving actually, but that is acting on intestine and causing this paralytic ileus. That's why too much analgesia after post-op also not recommended. We should give, but of course in a normal ranges. Pethidine, like say for example, mostly after heart surgeries we give pethidine to patients. So pethidine is a opioid. Okay, for next one we have this inguinal hernia. Inguinal hernia will cover from both. So first let me take the trampos. Okay, so for hernias, inguinal hernia is an abnormal protrusion. Hernia is always a protrusion, always an abnormal, protrusion from a normal opening. So it's a normal protrusion of intra-abdominal content through the inguinal canal. So normal inguinal canal, anatomical inguinal canal. If the abdominal content is coming through the inguinal canal, we can say it's a inguinal hernia. So inguinal canal, it's a normal anatomical variant, and if the abdominal content is coming from this canal, we can say it's a hernia. So it's one of two different types. One is called growing hernia, in addition to less common femoral hernia, and can be further subdivided based on anatomy. So that's normally called a growing site hernia, loin site hernia, iliac site hernia, not a femoral one. Femoral hernia is a separate one from where we will see from the femoral canal, if the abdominal contents are coming out, that is femoral hernia. So here also we have two kinds of hernia. One is called indirect hernia and one is called direct hernia. These are all the basic anatomical position. Now what is this basic anatomical position? Indirect inguinal hernia protrudes lateral to the inferior epigastric vessel through the deep inguinal ring, whereas direct inguinal hernia, let me show you the diagram so that you can easily get a clue. Maybe I should show this one. See, there's if you could just see the normal position. This one is inferior epigastric artery. So we will see the one who is towards the body. This is the body, right? Towards this side, and this is away from the body. So who is towards the body? We will say it's medial to this one. And the structures who are beside this area, towards this area, we can say this is lateral to epigastric artery. So there are two terms: medial to epigastric artery. This one is inferior epigastric artery, is an anatomical landmark, and this one is lateral to the inferior epigastric artery. So if we just go back and see here, if we are considering indirect inguinal hernia protrudes lateral to the inferior epigastric artery. So lateral means that away from the body, must be somewhere here. And whenever we say medial to the inferior epigastric artery, it should be the medial side. So let me take you to that diagram again. So this is inferior epigastric artery. So the hernia which is coming from this side, if it's protruding from this side, see the position here. This one is medial to inferior epigastric artery, and this one is lateral to inferior epigastric artery. So this is medial. So medial is called direct, and if it's lateral, it's called indirect hernia. So when we say indirect hernia, it's coming from lateral to inferior epigastric artery, and if it's coming medial means towards the body, then it's called direct hernia. So let me take you back through this one. It's very, very good in MTB, very crisp. You can easily digest from there. What page number on MTB? 777. See, it's mentioned here. Indirect hernia, there's a chart here, so just memorize this chart. Indirect inguinal hernia protrude by the internal inguinal ring, so it's coming out from the internal inguinal ring, lateral to the inferior epigastric artery. So whenever they're asking you the hernia which is coming through the internal inguinal ring and it is lateral to the inferior epigastric artery, you can say it's an indirect inguinal hernia. And the hernia who is protruding medial to the inferior epigastric vessel within the Hazelbach triangle. Hazelbach triangle, again, it's an apical triangle. I will show you this one. So this is called direct inguinal hernia. Let me show you. See, in particularly if you are saying this Hazelbach triangle, so one side is formed by inferior epigastric artery, one side is formed by inguinal ligament, and one side is the base. Let me, no, this one. This one. One side is inferior epigastric artery, one side is inguinal ligament, and one side is this rectus abdominis muscle. So this triangle is called Hazelbach triangle. This one side which is towards, we can say which is towards the body, that's a medial side. The medial end is formed by the inferior epigastric artery, the lateral end is formed by the rectus abdominis muscle, and the base is formed by the inguinal ligament. So this is the normal anatomical triangle. We call this inguinal triangle or a Hazelbach triangle. So if you could just remember this triangle, so if the hernia is coming out from this triangle, the hernia is going to protrude from here. And of course, this is the inferior epigastric artery, so that should be the lateral to the inferior epigastric artery. That is the indirect inguinal hernia. So let me show you here. Protrudes medial to the inferior epigastric artery, protrudes medial to the inferior epigastric artery vessel within the Hazelbach triangle. Okay, but this side, it's showing laterally. Okay. Sorry, my bad. This, they are showing this rectus abdominis muscle. So of course, the one rectus abdominis muscle is here, the another rectus abdominis muscle is here, and this penile and scrotal part must be here. So that wall, sorry, my bad. That wall is actually lateral wall, and this wall is medial wall because rectus abdominis is in the center of the abdomen, right? There are two recti abdominis muscle. One is here, and another one should be here. And from this part is the pubic part. So this is the medial side. So medial side is this one. So that's why we are saying this inferior epigastric artery, medial to inferior epigastric artery, there is a direct inguinal hernia. So please remember this one. This side is the lateral side. This side where the rectus abdominis is the medial side. So if there is a medial side, so of course this is medial, inferior epigastric artery is here. So whoever is coming out from this triangle, that should be a medial to inferior epigastric artery. So if this is inferior epigastric artery and the hernia is protruding through this area, so of course that should be saying that the hernia is coming medially to this inferior epigastric artery. So now we remember the boundaries of this one. So now this will become the lateral boundary, this will become the medial boundary, and this must be a base. So base is formed by the inguinal ligament. This medial boundary is formed by the rectus abdominis. Lateral boundary is formed by the inferior epigastric artery.
This.
Yeah, okay.
Yes. That was the right leg. This is the left leg.
Yes. So this is the lateral area, but just think about rectus abdominis. Where the rectus abdominis is there, that should be the medial side because rectus abdominis is just in the center of the abdomen. So that's a pubic area. This is a pubic area.
So that one coming through the medial to it will be direct, and coming lateral to the artery will be indirect.
Yes. So the one who is coming from this side, that must be a direct one, and the coming from this side, this one be a direct one. Exactly. So Hazelbach triangle, direct. Just memorize like this one. The direct must be Hazelbach triangle. So let us go back to the theory. Okay, so how the patient is going to present if he's having this inguinal hernia? First of all, if we are considering uncomplicated inguinal hernia, there is nothing complication there. So typically manifests as ill-defined mass in the inguinal region. There will be a mass, of course, and especially upon coughing, you will especially observe this one. The patient may present like during coughing, there is a mass protruding from the abdomen, increase in size when coughing or straining, decrease in signs on lying position. So whenever there is a lie position, the mass is going to get regressed. Decrease in size and lying supine. Now, inguinal pain is there or vague inguinal discomfort. So this is uncomplicated one. One uncomplicated one, when the patient cough, there will be increase in size. When the patient lie down, that must be regressed. For the physical examination, we will ask the patient to perform valsalva maneuver, and we will ask the patient to cough, and you can easily see the hernia is getting increase in size. So of course, that will give you a clue that this is a inguinal hernia. So it is completely reducible. When we say it's uncomplicated, it's completely reducible. But once it's incarcerated or once it's strangulated, we will say it's a complicated inguinal hernia. And this strangulation is very, very important here. Why? Because once the hernia is strangulated, you have only 6 hours to do the surgery on your patient, because after 6 hours, the necrosis of that area will be occurred. That's very, very important. So incarcerated hernia means that the hernia is not going to reduce at all. If associated with mechanical bowel obstruction, sudden onset of pain will be there, nausea, vomiting, constipation, and of course hernia you can easily say. So still incarcerated, still you have time to recover this one. But strangulated, there is too much strangulation, the ischemia or necrosis can occur. So of course you have very less time to do the surgery over this patient. So for the treatment point of view, of course, we always have to go for surgical. And what is the gold standard, therapy or gold standard treatment for this one? Surgical treatment, we'll always go for this one, mash repair. Where is mash repair? Let me take this one. This one. That is called as the gold standard for inguinal hernia repair. Please remember, for our exam point of view, that whenever we are saying that mash hernia repair, that is considered to be a gold standard for inguinal hernia repair when we are considering surgical option. And always we have to go for surgical option. Uncomplicated also, elective surgery, you have still time because the patient is not showing any signs of necrosis and all. So you can easily ask the patient, choose the date, whatever the patient suits to the patient, and you can go for elective surgery. For the conservative one, if the hernia is not very much big, you can go for the watchful waiting. But still, this one we have to clearly advise the patient that you have to come for the follow-up very early, very often, just in order to see whether the size increase or not, any signs of infection, inflammation, or any signs of obstructions are there or not. So surgical, always remember, herniaplasty mash repair is going to be the gold standard one. And if you don't want to place a non-mash repair, that is called herniorrhaphy. In herniorrhaphy, open surgical repair of hernial defect using autologous tissue. The same organ tissue we are going to use, the same person's tissue, same patient's tissue we are going to use here. We are not going to use mash. Mash is actually a synthetic fiber made up of synthetic fiber. It's a synthetic mash. It's not a patient own tissue. It's not an autologous tissue. It's a synthetic tissue. Okay, so let's have a look at the question here. Here the question says, a 28-year-old man presented with a 2-year history of reducible right inguinal hernia that became painful for 16 hours. See, he was having this hernia for 2 years. But for the last 16 hours, the hernia is becoming painful. Now it's showing the signs of obstruction. It is associated with progressive abdominal distension and vomiting. Physical examination confirmed the distended abdomen, exaggerated bowel sounds, tendurite inguinal swelling with the red discoloration of the overlying skin. It means that the signs of inflammations are there. That's why the hernia is painful now. WBC count, it's okay. It's not too much high. 9.8 still within the range. Direct abdominal exercise, multiple layer fluid levels. Whenever there is multiple layer fluid level, think about obstruction. So obstruction is there. WBC is okay. It means that there is no inflammation, there is no infectious thing, but obstruction is there. Now, which of the following is the most likely hernia complication? Tell me what will happen if for the 16 hours the hernia is painful. What can be there? It can be irreducible, obstructed, incarcerated, strangulated. Incarcerated is already under incarcerated thing. It's already ischemic. It's already showing pain. Now, what is the complication next? It can get strangulated. And once it gets strangulated, then only you have 6 hours for surgery. Other than that, the patient will go into necrosis and you have to remove the whole thing. There is no option. And death can also occur. That is a strangulated one, because they're asking which of the following is the most likely hernia complication. So hernia complication, when it's showing obstructed hernia, of course, you will think about strangulation. That is the most lethal complication. This question, a 34-year-old man who underwent an open repair of right inguinal. Yeah. Yes, sir.
It was already strangulated?
No, it was not already strangulated, but it was painful.
It was already obstructed?
Obstructed. That's why
it's already obstructed?
Yeah, that's why showing normal WBC count, but painful. So it means there is no inflammation, there is obstruction. That's why. So obstruction can easily go into strangulation, right? That's why the next thing you are going to choose strangulation. Yeah. Okay, for this one, a 34-year-old man who underwent an open repair of right inguinal hernia 3 years ago. Now, this is open repair. Already he has undergone this open repair. Presented with a 3-month history of right groin swelling that is associated with dragging pain. Now, again, he's having this groin swelling, and again, he's having this painful condition. Physical examination confirmed the right groin reducible swelling with positive cough impulse, reaching the neck of scrotum. So it means that this patient has a recurrent attack of this inguinal hernia. Now, recurrent means that because previously it was he was having an open repair, means the hernia portion was just stuck back. In open repair we usually do that, right? We just stuck back. Now this area again open, and this area again showing inguinal hernia. That's a recurrent inguinal hernia. Which of the following is the most appropriate next step? What you should do this time? Previously you did the open repair. You used autologous tissue to repair that. Now this time, what should be the gold standard thing? You should go for MASH repair. You should go for MASH repair. This time you should put some synthetic tissue, some synthetic material in order to prevent that, because last time you have used the autologous thing, right? Last time you did open repair. Open repair must be through autologous tissue. So that's why that autologous tissue must have gone autoimmune reaction, and that site again converted into hernia site, and that's why this time you should go for MASH repair. That should be the most appropriate next step. That's a golden standard therapy. Okay, so that's all for today. Thank you so much. Thank you, everyone. See you tomorrow.
Dr. Hira, I need to ask something from you.
Yeah, sure.
Yeah,
1 minute.
I just wanted to know. Okay.